and once it starts, it goes. Once stimulation is applied, it flows from cell to cell and then covers the entire heart. The area of the heart that contracts from one stimulation is called a myocardium. Now, the atria and the ventricles are separated electrically by the fibrous skeleton that we talked about. Remember that the atria are going to contract a fraction of a second before the ventricle because you want them to contract and fill the ventricle, make sure the ventricle is as full as possible so it's pushing a full load of blood out into the arteries and to the body, making it as efficient as possible. Now, there is a disease that's called atrial fibrillation, where the atrial, and we'll talk about fibrillation later, but where they don't contract right. People can live with atrial fibrillation because still about 80% of your blood is getting into the ventricles and out to the body. On the other hand, if you get something called a ventricle fibrillation, which I'm sure you've all seen in the medical shows, whatever, St. Elsewhere, Grey's Anatomy, Dr. Kildare, whatever, they go, oh, he's in V-fib, and then they grab the paddles and shock him to try to get the ventricles and the atricles back in rhythm. You cannot live with ventricle fibrillation. You are going to die within a couple of minutes. So that's why they absolutely will treat that. And we'll talk about how the current flows through the heart. The current starts at the sinoatrial node. That's the pacemaker. It's located in the right atrium. The pacemaker potential, slow, spontaneous depolarization. Again, this is where you're starting to get the contractions of the atrium. At about a minus 40 millivolts, the other muscles at a minus 70. Voltage-gated calcium channels open, triggering action potential and contraction. Repolarization occurs, opening the voltage-gated potassium channels. Now, this is where you have the importance of potassium and calcium in the heart. If you look at the calcium and the potassium values in the blood, they're kept in a very narrow range, because if you have too much calcium or too much potassium or too little, it's going to very much interfere with these calcium and potassium channels, and you start to see cardiac arrhythmias, and very, very much so with the minor changes in the amount of potassium. Too low, it's inhibitory. Too high, it's excitatory, or actually opposite of that. And you have a very narrow range at which your heart and body can function. You move outside of that range, you're looking at a potential of simply getting the heart to stop. In the same reason on the nursing floors, they've stopped leaving potassium out there, because if somebody picked up potassium as if it was some other drug and gave a big amount of it, they would kill the patient, and kill the patient very quickly because of the excess potassium. Okay. Pacemaker cells. Again, we're back to the electrical activity in the heart. The pacemaker cells in the sinoatrial node depolarize spontaneous, but at a rate which they can be modulated. Epinephrine and norepinephrine increase the production of CAMP, keeps the channels open, that speeds the heart rate. The parasympathetic neurons secrete acetylcholine, which opens potassium channels and slows the heart rate. Myocardial action potentials. Cardiac muscles have a resting potential of about a minus 90 millivolts. When they get up to the minus 40, they spontaneously depolarize. They're depolarized to threshold by the action of the potentials from the sinoatrial node, or the pacemaker, or the heart. Voltage-gated sodium channels open. The membrane potentials plateau at a plus 15 for 200 to 300 milliseconds. Due to the balance between slow influx of calcium and the efflux of potassium. As potassium gates are open, potassium comes in and repolarization occurs. Action potentials be spread via the intercalculated discs, the gap junctions, and then they get to the AV node. So the depolarization spreads across the atrium, causing the atrium to contract. At that point, it hits the AV, or the atrioventricular node, and then spreads through the bundle of His to conduct the stimulation of the ventricles. So it goes through the bundle of His and into the Purkinje system, and then spreads throughout the ventricles. This allows the ventricles to contract a fraction of a second behind the atrium. In the intraventricular septum, the bundle of His divides into the bundle branches. Bundle branches become Purkinje fibers, which stimulate the ventricular contraction. Sometime, either on your medical shows or as a nurse, you will hear of a bundle branch block. And this is where these electrical currents are not getting through. And then you may be looking at putting another type of pacemaker in order to deal with this, because this throws the heart out of rhythm. And here's a diagram of the electrical activity going through. Action potentials from the SA nodes spread rapidly, 0.8 to 1 meter per second. The AV node, it slows down. This allows the atrium to contract. Accounts for half the time delay between the atrial and the ventricle contractions. It picks up at the bundle of His, reaching 5 meters a second in the Purkinje. The ventricles contract 1/10 to 2/10 of a second after the atria. Again, that allows the atria to push the rest of the blood into the ventricles. Action potentials in the SA node. Because the atria and ventricles contract as single units, they cannot sustain a contraction. Because the action potential of cardiac cells is long, they have long refractory periods before they contract again. So they contract, and you're at normal heartbeat is 60 to 70 beats a minute, about 1 a second. It contracts, depolarizes, contracts, repolarizes, rests, and then depolarizes again for the next contraction. So the refractory period, or the rest, you have the refractory and the rest periods. Now we're going to talk about the electrocardiogram. It records, again, as I said, the electrical activity of the heart, picking up the movement of the body, the ions through the body tissues projected out to the skin. This is where you're painting an electrical picture of the conduction through the heart. As you move, by putting electrodes on the body, you can see this conduction, and by changing either the sequence or the position of the electrodes, you can paint about a pretty much a 360-degree picture of the electrical activity of the heart. Here is an electrocardiogram. You have your P, Q, R, S, and T waves. P wave is atrial depolarization. QRS is ventricular. ST is a plateau. The T wave is ventricular repolarization. Your atrial repolarization is hidden in the QRS wave, so you don't see it. Here is a typical electrocardiogram. Here's a diagram of how it reads and what's going on in the heart, and where the pulses are and where the contractions are. Again, this is where you're putting your leads. Right arm, right leg, right arm, left leg, lead 2, lead 3, left arm, left leg. Now we put a bunch of leads on, 8 or 9 all over the body, and then the computer separates and generates 12 lead EKG. Again, that painting a much clearer picture of the electrical activity through the heart. This is just, you're looking at a 3-lead EKG here. Again, you're just looking at where the leads go here, unipolar between the single electrode, the body, one into the machine. Limb leads go to the right arm, and left leg. And there are 6 chest leads. This is in your book on electrocardiograms. Okay, EKG and heart sounds. Lub occurs after the QRS wave. The dub, again, you're looking at the repolarization of the ventricles. It's at the beginning of the T wave because the depolarization has already contracted the ventricles. As they repolarize is your T wave. So logically, the dub would be right at the beginning of the T wave. Okay, here we're detecting ischemia. Ischemia is a breakdown or a death of heart muscle from one area or another. And what you're seeing is, one, a lengthened ST and a depressed S wave. And you would see that on the EKG looking for a heart attack, looking for some sort of heart muscle damage. Abnormal arrhythmias. Bradycardia is a slow heart rate, tachycardia is a fast heart rate. Ventricular tachycardia occurs when pacemakers in the ventricles make them contract out of sync with the atria. It's very dangerous, lead to ventricular fibrillation. Like I said, they all yell, he's in VFib or he's in VTAC. They get out the paddles and they shock him to try to get it into a normal rhythm, and that's called a normal sinus rhythm. A flutter is extremely fast but coordinated contraction. A fibrillation is uncoordinated, pumping between the atria and the ventricles. Here are just some diagrams on the EKG. Types of fibrillation. Atrial result in an atrial flutter. Atrial muscles cannot effectively contract. AV nodes can't keep pace. Reduces cardiac output, I was saying, by 20%. This is by 15%. Increases the risk of stroke and heart failure. If you have atrial fib, they are absolutely going to put you on Coumadin or warfarin, Plavix, something that's going to keep you from clotting as easily, because this flutter and this regurgitation and poor blood flow is a just asking to throw a clot. And so they will put you on some sort of blood thinner to keep you from throwing a clot. Via ventricular fibrillation, you can't pump blood. And you're going to do CPR until you get an electrical defibrillation to get reset your heart rhythm. That's what we talked about, the paddles. AV node block is seen in the PR interval. As the PR gets larger, it exceeds 0.2 seconds. With a second degree, that's first degree. Second degree, the electrical waves cannot pass to the ventricles. Third degree is complete. No stimulation gets through. You do have a pacemaker that's built into the Purkinje fibers that takes over 20 to 40 beats per minute. So you can live until they can get in and put a pacemaker in, but you're generally on your back, and if you've got oxygen, you're doing better, but you're sucking for air because you're moving some blood, but not enough to do anything, but just lay there and try to stay alive until they can get a pacemaker in. Okay, let's see if I've got anything else here. And I think that's it. I've lost part of this. Okay, we're going to stop right now and go on. I'll come back with the rest of it, but I'm going to get this kind of mixed and out. Okay, thank you.